Here is what nobody is telling men who start taking GLP-1 drugs like Ozempic or Wegovy. The weight you lose is not all fat. A significant portion of it is muscle. And for men over 35, that is not just a fitness inconvenience. That is a longevity emergency. The research is clear. Studies tracking body composition in GLP-1 users consistently show that lean muscle mass drops alongside body fat. And for men whose testosterone is already declining at roughly 1 to 2% every year after 30, the combination creates a biological cascade that most prescribing physicians are not discussing with their patients before the first injection. You lose weight, you feel better, you look thinner, and underneath the surface, your muscle is disappearing, your testosterone is spiraling, and the very foundation of your long-term health is quietly eroding. Today on Mangevity, we are going in deep on exactly what happens when GLP-1 medications meet declining testosterone in men over 35, what the research actually says, and what you can do to protect yourself. Quick disclaimer, this is educational content based on research. If you have serious concerns, talk to a healthcare provider. GLP-1 receptor agonists, the class of medications that includes semaglutide, sold as Ozempic and Wegovy, and tirzepatide, sold as Mounjaro and Zepbound, work by mimicking a hormone your gut naturally produces after eating, signaling to your brain that you are full, slowing gastric emptying, and dramatically reducing appetite and caloric intake. The results for weight loss have been genuinely remarkable by pharmaceutical standards, and around 1 in 5 American adults have now used a GLP-1 medication at least once. But here is what the mainstream conversation has been consistently underplaying. When you create a significant caloric deficit rapidly, your body does not selectively burn fat. It burns whatever is most metabolically expensive to maintain, and lean muscle mass is at the top of that list. Clinical trials of semaglutide published in the New England Journal of Medicine showed that approximately 25 to 40% of total weight lost on GLP-1 medications came from lean body mass, including muscle tissue, not stored body fat. For a man who loses 40 pounds on Wegovy, that could mean 10 to 16 pounds of that weight loss was muscle he spent years building. The daily impact of this muscle loss is not always immediately visible on a scale or in a mirror. It shows up as fatigue that does not resolve with rest. It shows up as workouts that feel harder with less output. It shows up as a metabolism that has slowed because muscle is the primary driver of resting metabolic rate, meaning the less muscle you have, the fewer calories you burn at rest, making long-term weight maintenance significantly harder even after the drug is working. It shows up as reduced grip strength, slower recovery, and the kind of general physical decline that researchers associate not with aesthetics, but with all-cause mortality risk. A landmark study published in the British Medical Journal found that low muscle mass in middle-aged men is one of the strongest independent predictors of cardiovascular disease, metabolic dysfunction, and early death, stronger in many analyses than cholesterol levels or blood pressure alone. Now add the testosterone dimension, and the picture becomes significantly more alarming. Testosterone and muscle mass exist in a bidirectional relationship. Testosterone drives muscle protein synthesis, and adequate muscle mass helps maintain healthy testosterone signaling. When GLP-1-driven caloric restriction causes muscle loss, it removes one of the primary physiological supports for testosterone production. And this happens in a population of men, those over 35, whose testosterone is already declining at a documented rate that most of them have never had measured and would not recognize if they had. The American Urological Association estimates that testosterone deficiency affects approximately 40% of men over 45, and the vast majority of those men have never discussed it with a physician. For these men, starting a GLP-1 without addressing testosterone and muscle preservation is not a complete treatment plan. It is an incomplete one with serious downstream consequences. Now here is where the story gets more complicated and more urgent, and where the medical establishment is only beginning to catch up. The relationship between GLP-1 medications and testosterone is not a simple one-way street. Early research suggests that GLP-1-driven weight loss can actually improve testosterone levels in obese men because visceral fat, the deep abdominal fat that accumulates around organs, converts testosterone to estrogen through a process called aromatization. Reduce that fat, and in some men, testosterone improves. This is real, it is documented, and it is the reason some clinicians argue that GLP-1 medications are net positive for testosterone health in overweight men, and this is the critical distinction that the headlines are missing, this benefit applies primarily to men with significant excess body fat and testosterone suppression driven by that fat. For men who are moderately overweight or who are using GLP-1 drugs for body composition optimization rather than clinical obesity, the picture is entirely different. In these men, the testosterone positive effect of fat loss is smaller, while the testosterone negative effect of muscle loss and caloric restriction is proportionally larger. Caloric restriction itself is a documented suppressant of testosterone production. Research published in the Journal of Clinical Endocrinology and Metabolism found that men in significant caloric deficits showed measurably reduced LH pulsatility, the hormonal signal from the brain that tells the testes to produce testosterone. In plain terms, when your body thinks it is starving, it reduces testosterone production because reproduction and anabolic processes become low priority relative to survival. GLP-1 medications create exactly the kind of sustained caloric deficit that triggers this response, particularly in the early months of use when appetite suppression is most aggressive. The result is a man who is losing weight, losing muscle, and experiencing the symptoms of declining testosterone, fatigue, reduced libido, brain fog, irritability, difficulty building strength, while his physician is focusing entirely on the number going down on the scale and calling it a success. Here's the suspense, and here is what every man over 35 taking or considering a GLP-1 needs to understand before he injects dose 1. The drug is a tool, not a complete solution. Used without a deliberate strategy for muscle preservation and testosterone optimization, GLP-1 therapy can leave a man lighter, weaker, hormonally depleted, and metabolically worse off than a well-executed diet and training program would have achieved. The research emerging from longevity medicine conferences in 2026 is beginning to name this explicitly, that the combination of declining testosterone, GLP-1-driven muscle loss, and the age-related phenomenon researchers call sarcopenia represents one of the most significant under-addressed threats to men's health span in the coming decade. Sarcopenia, the progressive loss of muscle mass with aging, already begins measurably after 30 and accelerates after 50. GLP-1 medications, without protective countermeasures, can accelerate that curve significantly in men who are already in the at-risk zone. The solution is not to avoid GLP-1 medications. For men with significant obesity, metabolic syndrome, cardiovascular risk, or type 2 diabetes, these drugs represent a genuine and potentially life-saving intervention, and the clinical evidence supporting them is substantial. The solution is to use them correctly, with a protective framework that addresses the muscle and testosterone risks that the prescription alone does not cover. The first and most evidence-supported protective measure is resistance training, and the research on this is unambiguous. Multiple studies examining GLP-1 users who maintained a structured resistance training program showed significantly greater preservation of lean muscle mass compared to GLP-1 users who did not train, with some studies showing that progressive resistance training can reduce muscle loss from GLP-1 therapy by 50% or more. The goal is not complicated. 3 to 4 sessions per week of compound multi-joint movements, squats, deadlifts, rows, presses with progressive overload. This is not optional maintenance. For men over 35 on GLP-1 therapy, this is the primary countermeasure against the most dangerous side effect of the medication. The second protective measure is protein intake, and the target is higher than most men expect. Research consistently shows that the recommended daily allowance for protein, 0.8 grams per kilogram of body weight, is dramatically insufficient for muscle preservation in men in a caloric deficit. The evidence-based target for men over 35 using GLP-1 medications is between 1.6 and 2.2 grams of protein per kilogram of target body weight per day, because GLP-1 medications reduce overall appetite and food intake. Getting adequate protein requires intentionality, prioritizing protein-dense foods at every meal, using protein supplementation if needed, and tracking intake at least during the first months of therapy. The third and most underutilized protective measure is testosterone evaluation. Before starting a GLP-1 medication, men over 35 should have their total testosterone, free testosterone, SHBG, LH, FSH, and estradiol tested, ideally twice in the morning on separate days. This baseline is not just useful at the start, it allows for monitoring throughout GLP-1 therapy to identify if caloric restriction and muscle loss are driving clinically meaningful testosterone decline that requires intervention. Research from the Clinical Application of Longevity Medicine 2026 conference presented emerging data on the potential synergy between GLP-1 therapy and testosterone optimization, suggesting that men who address both simultaneously may achieve superior body composition outcomes, including greater fat loss and greater muscle preservation, than those using either intervention alone. This is the frontier where the science is moving, and it is moving fast. For men over 35, the key takeaways are this: get your testosterone tested before and during GLP-1 use. Train with resistance 3 to 4 times per week. Hit your protein targets every day, and work with a physician who understands both hormone optimization and the body composition realities of GLP-1 therapy. If you are benefiting from our topics, please subscribe, like, and turn on the bell notifications so you can see our new videos early.